Okay, everybody, settle back in your seats. Hope you had a nice lunch break. So we're in for a real treat in probably the hardest slot of the day, post-lunch. Do you remember back in December we were talking about nudge and the little book, which has really great case studies about behavioural change and behavioural insights. And we referenced a lot of the work that Dan's team in the Cabinet Office have been doing. So it's a real privilege to have Dan with us today, who's going to give us a little insight and tour around behavioural insights and some of the work they've been doing. And there'll be time for questions at the end. So keep those stored up and we'll take questions and have a discussion at the end. So Daniel, over to you.
Thanks very much. Can you hear me with this mic here? Okay, good. I'll try and stay within vicinity. I've got this danger of roaming, and I've decided to put the clicker down, and then I might need to stay where I am. So I'm from the Behavioural Insights team in the Department of Health, and as is on the slides, I'm on secondment to NHS England at the moment. And I think that shows this stuff's really kicking off, and I'll tell you why I think it's important. The intro suggested that you had at least some of this in a previous session, so most of you have come across the term nudge and behavioural insights or behavioural economics. Does anyone know the difference between nudge, behavioural insights and behavioural economics? No, they're basically the same thing, just to clarify some of this jargon, because I think if anything, this is all really simple and really intuitive, and it's stuff that we could quite easily incorporate into our day jobs, but some of the language makes it sound a bit more highfalutin than it actually is. So it all means the same sort of thing, and it's the science of decision making, how people make decisions. So that could be decisions you do once, or it could be a long-term decision. So behavioural science, decision science, all the same sort of thing. I'm going to talk you through a few examples of the work that my team in DH has done, and these are all relevant, recent NHS examples of where these approaches are making an impact. And for you to take something away, so I'll show you some examples. They may directly resonate with your challenges, they may not, but there may be a component of it. I'm going to reference a framework that you can actually take away and work through, and it's just 4 things. I'll do it with examples. So to kick off, this may be the sort of challenge that you face in the jobs you do. This is patients who fail to attend a medical appointment. So this is national stats, about 1 in 10 medical appointments are missed, patients don't turn up, and let's assume they should be there for a good clinical reason. So that's bad for patients' care, and it wastes a lot of money. It's quite difficult to calculate the waste, but some people have put very big numbers on it. That's the National Audit Office figure. So there are lots of things we can do about that. Some fairly obvious things like why not put on more conveniently timed clinics. Perhaps some more controversial things like you could fine patients who don't turn up. That's often discussed, more controversial. But here's some criteria for you, just a little brain task. What could you do to reduce missed appointments by, let's say, around 1/4, but to meet that criteria there? So you're not allowed to spend any money, not a penny. You can't do anything that needs complex system change or require a lot of staff training. And you can't penalise patients, so that excludes the fining patients option. That's a tough set of criteria, I think. If you've come across some of the work we've done before, you may know the answer, so I'm going to skip ahead here and show you what we did. So we tested a series of things at Bart's Hospital. This was about 2 years ago. Some of you might work at Bart's. And what we looked at was the reminder message, the text message reminder that a lot of patients are sent before their clinic. Reminders work because one reason patients may not attend is they forget. That's not rocket science, so remind people. But we use behavioural science to get the precise wording of that message right, which may not seem like it's very important. If you're reminding someone, this is the standard message at Bart's. So your appointment is at location, date and time. To cancel or rearrange, call the number on your appointment letter. So it's got all the details you need, but could you get better value by tweaking that a bit? Yes, you can. So we tested a whole bunch of variants of this. I'll just show you a couple. We tested one we called the easy call message, and this is the most obvious thing we've ever done ever. We put in the number, so it's easier to cancel or rearrange. I think that is really powerful in that this is not rocket science, but we're doing obvious things that BARTs were not already doing. No one thought of it. You can, of course, get the number to cancel or rearrange. It's on the front of BART's website. It's probably on your appointment letter. But that ain't the way people are in real life, is it? So this is all about adapting to actual human behaviour, so make it easier for people. It's a bit more jargon here. We use a social norms message, so we added in that 9 out of 10 people attend. So to communicate that sense of what most people do, all of us, all of the time, are influenced by what people around us do, but without us consciously thinking about it. We just copy other people. So let's use that. If that's positive, let's deliberately communicate that. Let's just go with the flow of that weird quirk of human behaviour. So a social norms message. And the last one, which was the most effective one, I'll show you the results in a sec. We told patients the specific waste to the NHS of not attending. This is quite unusual in the NHS. We don't often communicate the cost of things to anyone, actually. We said not attending costs the NHS £160 approximately. We didn't give a general figure. We didn't say not attending wastes money. We were very specific, a tangible number that people can visualise in their head. £160 is, to most people, quite a lot of money. And people care about the NHS. So your actions could cost the NHS that you care about a lot of money, is what we're saying. We're not penalising the patient in any way. So we run that as a trial. I can talk afterwards. If you're interested, I'll talk a bit about how we do evaluations, but I'll skip over that for now. We tested it in real life. 10,000 patients were randomly assigned one of those different messages. And if you can pick out the graph there, that one on the right, the one I went through last, that reduced missed appointments by about a quarter. And it met all that criteria I went through. It was entirely free. It didn't require any system change to do it, just took the outpatients manager a few seconds to type in. And we've not penalised patients in any way. This is in use at a few hospitals. I know it's in use at King's in South London, and they told me they've had their lowest ever recorded missed appointment rate just by changing their text message. So a few lessons from this, and if you've come across behavioural insights before, is it rocket science? No. Does detail really matter? Yes. And some of it may be a little bit counterintuitive. You may not expect that sort of feedback around costs makes a big impact. It's not the sort of thing that we often do. So it creates great potential to do new things that are free, really easy to scale up, and don't penalise anyone if they want to carry on as they are. So that's what I just run through, that criteria. Cheap, scalable, and light touch. It's another tool in our toolbox. Integrate it into what you're already doing, and it can be really easy and pay off big time. Some of the complexities around this are that, I'll show you that in a sec. If what we're saying is that human behaviour is driven by lots of these weird things, we're not rational machines that weigh up the pros and cons of things. You can actually make substantial differences to human behaviour by doing a couple of weird little things. That feels quite difficult because we're saying, oh, the world is much more complex than maybe we like to think of it as. So, blimey, what do we do about it then? And it's really difficult. But scientists we now better understand that than ever. There's been 30 or 40 years of massive breakthroughs in psychology and decision-making science, and people turning that into useful tools that we can actually apply. We don't need to worry about hundreds of things. We can just apply it. I'm going to skip that. So that's a list of some of those behavioural concepts, these odd ways that people behave, and they've all got fancy names. Scientists like giving things names like the availability heuristic, which just means about something being available. My favourite is the optimism bias, which is just people who are optimistic, but there's a lot of jargon. Don't worry about it, is my message. There's a framework, which is this one, which is what I'm going to run through in the next 15 minutes. 4 top tips of applying all of this complexity to your jobs. And hopefully you'll see in some examples I'll talk through some things that are hopefully relevant to the challenges that you face in your job. So I'm going to run through that framework really quickly. We can send a link to this afterwards. So if there's one thing you do after, it's have a browse through that framework on the bus home or something. It's quite a nice read. There's lots of case studies. So the first part of those 4 headings is making things easy. I think we all know this, that if you want someone to do something, make it easy. But we would systematically underestimate quite how important that is. So we all know that a short letter is better than a long letter, but our day-to-day gets in the way of that, and we end up writing a long letter because we want it to be comprehensive, and then the lawyers checked it, and then we thought, oh, let's say something else while we're sending a letter. Before you've done it, you've actually made a bad letter and no one reads it. So just an example, don't underestimate the power of making things easy. That's my top tip, make things easy. And here's an example. This wasn't a study I was involved in, actually. I think the rest are. This was a piece of research at Imperial in West London, and it was looking at redesigning the prescription chart that hospital doctors use to try to reduce the chance of error. This is the new one. I've not shown the old one. But basically, all right, there's a stereotype. Doctors have terrible handwriting. I'm sure there are some doctors in the room who can correct me on that if I'm wrong. But this could have very significant repercussions. So the example here, I'd point at it, but if you're scrawling micrograms or milligrams, that could quite easily be misunderstood when the drugs are dispensed. And that could therefore get the dosage out by a factor of 10, I think? Significant patient safety risks by a very simple error. So one thing that this chart did was that you circle micrograms or milligrams. So simple. We're not claiming this is complicated, but we are saying people get it wrong all the time. The results there may be a bit tricky to pick out, but making these simple changes, like simple prompts so that people print rather than scrawl, massive impact on patient safety measures. I mean, just to take one, the third bar chart along, frequency of medications entered correctly. This is completely correctly, we were very strict here. Went up from only about 10% to nearly all of them, just by these simple behavioural design changes to make it easy for people to do what they want to do anyway. No doctor wants to write a prescription that's difficult to translate. That's not anyone's aim, of course, never. But day-to-day gets in the way. You can make some simple changes. So that's E for easy. The next one is making things attractive. There's quite a lot under there, so I'm not going to try and summarise all of these headings, but I'm going to show you an example, and this is a study that we did in DH about a year and a half ago. This is a screenshot of an alcohol health charity called DrinkAware. So people might find themselves on the website if they've got a concern about their levels of drinking or maybe a family member's drinking. So these are people actively seeking information about a lifestyle change. And the message is fairly typical public health message. Is alcohol affecting your health? Cutting down can reduce your risks of irritable bowel syndrome, cancer, liver disease. So what you want people to do is to make health improving actions, and to do that we use a health message. We contrasted that with this message. Is alcohol affecting your appearance? Cutting down on alcohol can reduce your risk of saggy skin, obesity and premature aging. Okay, so just to be clear, from NHS England, we're not really bothered about saggy skin, right? This is simply about what appeals to people, what matters to people right now. And frankly, we should just go with that. So the here and now, which may be an appearance type concern, may be more important to people than a very long-term risk of liver disease that's quite difficult to think about and act on, especially if you're young. That thinking about a risk in 30 years is quite tough. So we're just going with the flow of what influences people, what people find attractive to them. And in this case, it may be appearance messages. Does anyone want to guess about the impact this had? So this message was 15% more effective in people taking health action, and we measured that in a few ways, but only with women. With men, there was no difference. That always gets a laugh, mostly from the men. We think actually it's not because men don't respond in the same way, it's because the campaign was very female-oriented. There's a picture of a woman. If we'd have worded it differently, cutting down can make you more buff or something more masculine, we might have got the same effect. So it's not men and women are different. I'm just giving you the truthful answer. This was important to women. Let's go with it. I've got two more, and then we can stop for some questions. So the S is for social, and this is, I've touched on this a bit already when I mentioned that text message, communicating what most people do. And I've got another example of this. This is influencing GPs. So there's a crisis in this country of antibiotic resistance. Well, there's a crisis across the globe of antibiotic resistance. One thing country is to make better use of the antibiotics we have already. So let's not prescribe them when they're not medically beneficial. And GPs prescribe at very different rates. Some GPs prescribe lots, some GPs prescribe much less. There's some good reasons for that, and there's some less good reasons for that. So what we did about 18 months ago, this was led by Public Health England, we ran it as a trial. We sent the GPs who prescribed the most antibiotics in England, about 1,500 of them, they were randomly allocated to get this letter or to get nothing. And the letter does, well, it does a few things, but the main one I'll pick out is that statement in bold. It says, the great majority, 80% of practices in your area, prescribe fewer antibiotics per head than yours. And then we've picked out some top tips. You know, we've distilled the good practice guidelines into, look, here's 3 things you can do right away, not 28 pages of nice guidelines to read. And then we measured the impact over a very long period, over at least 6 months. This letter, a very robust evaluation, it's just about to be published in the Lancet. This letter had a sustained, reduced prescribing of about 3.5%. Just by sending one letter. That may not sound like a lot, but actually in prescribing habits, that's massive. And to put it into context, the government is also offering some incentive payments for GPs, and they get, it's a bit more complex than I'm going to summarise, but they get a share of about £13 million if they reduce their antibiotic prescribing by 1%. So we got many times bigger impact than that just by sending one letter once, which cost in stamps and envelopes about £4,000. So it wasn't quite free, actually, but it was nearly free. £4,000 ain't bad in this context. And the last one, T is for timely. So it's not just about what you communicate, but about when you do it, precisely when. And here's an example. It's about costs again. So again, drawing from that text message example, we communicated to patients the cost of not attending an appointment. In this case, and there's a couple of trials here, we communicate to clinicians the costs of different lab tests or types of drugs at the time they decide whether to use those or not, or between alternatives. So for example, that's a screenshot of an online prescription system in, I think it's in Nottingham Hospital. And at the time when GPs make a decision about different types of drugs, they're reminded of the cost, and the cost can vary, just example here, from 4 pence per day to £12.54 per day. And of course there are good clinical reasons to do the cheap one or the expensive one sometimes, but that grey area in the middle, we're just providing some more information. We're not restricting clinical choice. We're not even actively persuading doctors to say, please, please, please use the cheaper one. We're simply providing timely information. That trial's still underway, but another trial, which is where the reference is and the post-it, was used a similar concept when doctors on a ward may order a common lab test. It's the sort of thing they'd order for every bed. And at the time when they decide whether to order that, they were just reminded the test cost £1. It's actually a cheap test, but we still said this test costs £1. And it reduced use of the test by 1/3. The medical director was involved in the evaluation. We couldn't detect any adverse clinical reactions, so we can suppose to a good extent these were just unnecessary tests. And just by providing timely information, in this case about costs, but it could have been about something else, you make a really big impact, and that's worth, just for that one test that cost £1, if that was scaled up across the NHS, that would save £3 million a year. So that would pay for my salary for a couple of years. You know, these things could, this big impact. Just for some further reading, I'll stop now for questions and discussion. If you want to take anything away, so the framework I mentioned is EAST. We'll send a link round to that. Do please have a look at that. There's one thing you do. And there's a couple of other books if you had a bit more time. The one on the left is a recent Health Foundation report looking at opportunities for behavioural insights in healthcare. It's got lots of case studies, and it specifically says, look NHS, here are some areas where it's most amenable to these approaches. And then the one in the middle is a book by Professor Daniel Kahneman, who won the Nobel Prize in Behavioural Economics. So if you're really keen, it's a great read actually. I'd recommend that as well. I'll stop there for questions. If we've got 5 minutes at the end, I've got a game for you, but if not, we can do that another time.
We love games, so I think we're going to take you up on that offer. There's lots of people working on stuff which is pretty similar to some of that, right? Quite a few teams working on DNA rates. So something must have resonated. What questions have we got in the room? that you'd love to put to an expert in how to influence people's behaviour?
Thanks, Dan. Really enjoyed that. One of the thoughts that I had while you were talking was, when we're implementing a quality improvement model, we often talk about the different types of measures, whether that's outcome measures, process measures, and balancing measures. And you presented there some information on the outcomes, the impact that your interventions have had. And it was actually only your final example, which was, I think you said the medical director did an assessment of any kind of adverse effects. My question was around balancing measures. So if you've implemented all of these change ideas, what balancing measures do you have in place to see what impact the changes are having in the other direction?
It does vary a lot. It's a really good question about outcome measures. First of all, I should say that we've run a lot of these projects on the principle of what can we do with things that are already measured, already collected. And that's partly just being pragmatic, because these are all done on a bit of a shoestring, actually. The missed appointment study cost in total, other than my time and a colleague's time, costs £5,000 in total. So all a bit cheap. We could have probably measured a bit more. But we tend to go with what's already there. So to take an example again on the text messages, we wanted to see whether there was any negative feedback from patients. So we engaged with the PAL service at Barts. It got to the point when they'd sent out 40,000 text message reminders with our new message, and I think PALS had about a dozen queries. And most of those were people just who weren't sure whether they were being fined. Which I think the text is clear, but you can see people are busy and they may have misunderstood. So we just use existing sources. I'm sure there's more we could do in some areas as these approaches are scaled up, and maybe I'm not a proper academic, I'm just doing this from the civil service. As more academics are involved, and there are some, we could probably do a lot more to make sure we don't have unintended consequences.
Thanks, Dan. There was another question here. Guy, I'm going to run over to you.
Hi, I was particularly interested with actually your attempt to try to reduce the number of people that don't go to appointment. You mentioned the last part was effectively to try to kind of make feel people a bit guilty about not attending, but saying it costs so much money. This is what it costs. Would it be possible for people that are actually repeated offender? I think it must be the mass majority of people that do not attend are actually people that keep doing that over and over again. To let them know that if they already missed an appointment, to let them know you missed so far 1 or 2 appointments. To make them aware how many they missed so far. So added on to the fact that they already cost money, this is the amount it costs per not attending per session. Let them know that effectively they already missed twice or once. If they haven't, well, fine, probably not mentioning it. But as a text, adding this on, do you think that will make a difference?
Yeah, I think in a lot of these areas there's lots more that we could do, and we'd love to. And this may be the territory of, you guys can build on this. We started off with an intervention that was just one thing, really simple to roll out for everybody. So we just did one thing. It wasn't tailored at all, and there was no specific different follow-up for different groups. There is great potential if you were able to do that, and to tailor on different types of patients, maybe, as you say, following through their behaviour if they're repeat non-attenders. Great potential. This is really early days. That's why it's really exciting. We've only been doing this collectively from the Department of Health and Cabinet Office for 3 or 4 years. There's tons of potential.
I just want to say something about DNA rates being what's called an interface variable, because when somebody gets, I'm a GP, so when I refer somebody for a test or I do a test, it's about getting consent. And consent is about health literacy, both my health literacy and the person in front of me's health literacy. So when we look at DNA rates, we often look at it in a very black and white way, rather than understanding that actually it's a moment that happens between in fact, two boundaries of care, or crosses boundaries of care. So I just wanted to sort of think about this interface variable aspect of it.
Yeah, you all, many of you in the room know much more about this than me. We just wanted to do one thing that could take a chunk out of a problem there'll be lots of other things, lots of other opportunities with a more rounded understanding. So even at Bart's, we got a quarter reduction in their missed appointment rate. There's still 8-point-something% of patients who don't attend, and there'll be lots of complex reasons why that is and different opportunities to influence. I don't know if that's fully answered your question. I don't know enough about that interface point to... Yeah. Agree, yeah.
So who's got a change idea on their driver diagram that the EAST framework might help you with? Something that you could do that's easy, changing appearance, something to influence the social aspect of it or the timeliness of a change?
I guess this talks more to the appearance, the kind of attractiveness, and that is where some of my projects about getting the awareness of a carer support group increased on an inpatient unit. So we're looking at the sort of material, we're doing a lot of different bits of that, but part of it is looking at the materials we're using to kind of tell people about the group. And I was just, so it just came to my head that with how you word kind of certain posters or materials to catch the eye or where you put them, there's probably quite a lot in that we could think about in terms of how we would sort of increase the awareness of this group happening. I don't know, it's not really a question, it was more just came to my head. Yeah. I don't know if you've got any ideas about that.
I agree. I think that document, if you take a look, may give you some more specific ideas. Just a couple of thoughts. One is that people who are very good at social marketing are probably drawing on a lot of these approaches already. They just may not use the same jargon, so there's a lot of expertise. The main problem with social marketing, I found, and I'm happy to have a heated debate with anyone in the room who works in social marketing, is they're normally really poorly evaluated. So typically you only evaluate by asking people, do you like this? Do you understand it? And things like that. When actually, I think a big lesson from behavioural science is that actual behaviour is driven by a lot of complex things that are quite difficult to reflect on. So the only real way to know whether something works is to observe actual behaviour rather than say to someone, do you like it? So if you do try something new, try it in real life and see what the effect is on behaviour. There are lots of ways to measure that rather than just asking people.
Hello. Oh gosh, that's loud. I want to stand up. Hi. I love this stuff. I think like the potential of it is really, really exciting. I was just wondering, as a kind of full-on expert, when you and your team approach a problem for the first time, do you have any tips for how you come up with ideas? Do you kind of go down the pub, or do you just or do you do like groups brainstorming? How much do you get the team involved and stuff like that?
Good. So that's a great prompt. So I guess we do two things. First of all, we look at what's already in place and what can we just optimise. So again, having to run this on a bit of a shoestring, and the best way to get quick action is just to see what are you already doing and can we tweak it a bit. So you're already sending a text message. Can we just change the wording a bit? You might already have a marketing campaign. Can you just change it a bit the next time you refresh the posters, that sort of thing. And the second one is, we've got, we use the EAST framework, easy, attractive, social and timely. That's 4 things to run through. Under each of those there's 3 or 4 subheadings. So we literally sit at a team meeting. We've turned it into a bit of a game actually. I will send this to you and you can print it out. We've turned it into a card game. So each of these concepts have got a card and we just throw them around the table and generate ideas. And then we may go away and look more closely at the evidence. But I'll send it around. You have to print them out. It's not very high tech, I'm afraid. But it's really nice just to get the team involved in brainstorming.
Hi, I'm one of the QI leads on the team. I'm Jen. Thanks so much so far. Just a question. I'm just interested in the area of competition and sort of competition as being something that underlies change ideas, because we've had some success with that actually in the trust, but then there's something around that being extrinsic motivation versus intrinsic. So is there anything from the evidence base or from your experience in that area?
What competition in what sense?
So ideas which promote competition between people as kind of a motivator for change. So we had a project in mental health care for older people that kind of encouraged competition between the wards in terms of how they were doing around missed doses of medication. And we saw a 90% decrease in that project. Yeah.
I guess under that there's quite a lot of separate concepts, and I'm a very dangerous risk of getting into a lot of horrible jargon here, but one is the sort of not letting the side down effect. So if an individual is asked to do something, I mean, we did something in my office recently. We had a stairs challenge for January, walking up the stairs, but we broke the team down into groups. So rather than me, winning the competition, and frankly, maybe I didn't really care all that much, but I didn't want to let my little team down. So I probably walked up more stairs because I didn't want to let other people down. And there's also things, as you've set out, showing who's doing what, leaderboards and things like that, and quite how you communicate that to people. Maybe it's a good chance to prompt about the social norms message. So if people are doing well, communicate that. If people are not doing so well, don't communicate that because it shares a negative social norm. And the other risk is that antibiotics letter to GPs I mentioned. We didn't send that to the GPs who do the best, who prescribe the fewest antibiotics, because we feared they may take their foot off the pedal. You may want to do something different. So think about how you communicate, and maybe you have slightly tailored messages whether people are above the line or below the line.
Thanks, Dan. Really interesting stuff. Time for a game?
Time for a game. Yeah, okay. I didn't bring a prize, though. You just have to, well done to whoever wins the... I think you may have come across this project in one of the previous discussions around nudge, behavioural insights. If you have, just keep it to yourself. So this refers to a trial we did 3 years ago now. It was one of the first big trials looking at could you apply behavioural insights to health challenges, and this was to encourage people to join the organ donor register. And we did two things. I'll run through quickly the first thing, and then the second thing is the game. The first thing we did is we simply now prompt people to join when they're doing something completely different. So in this case, it's when you're renewing your car tax online, or when you're getting a driving licence, you're prompted to join the organ donor register. And that's very effective. It's now the third most common way people join the organ donor register in England. And the basic principle there is that most people, in fact 9 out of 10 in surveys, are very happy for their organs to be used after they die. But we just never quite get around to joining the organ donor register, to expressing our wishes. So you prompt someone when they're doing something else. And the government runs the websites for car tax, so it's easy for us to make that change. The second bit, which is the game, is, well, once people are on that website, and we prompt them, thank you, please join the NHS organ donor register, and you can join or you can just shut down the web browser and carry on about your day. Could we add in another message or a picture to further motivate people to join? And we thought we could, but we didn't know what the message or picture should be. We did some brainstorming about ideas. We came up with 8 variants, and we tested them in real life. So 1 million people were randomly assigned one of 8 different messages and pictures. So I'm going to run through the 8 quickly. Keep in mind which one you think was best, and then I'll go back through and you put your hand up to say which one you think was most effective. And I'll give you the result first of all. The difference between the best and the worst of these was about 1/3, and that equates on its own to about 100,000 additional organ donor registrations per year. So this is big impact just by the tiny difference I'll show you. So the first one of the 8 is this one. Let's call it the simple one. Just the thank you, please join the NHS organ donor register. Number 2 has a social norms message. So every day, thousands of people who see this page decide to register. So number 2, social norms. Number 3, another social norms message, but with a picture, so to sort of further underline that sort of sense of everyone's doing this. So number 3, social norms with picture. Number 4, another social norms message, the same one, but this time with the NHS logo. That was sort of an authority figure. People care about the NHS, so let's use the NHS organ donation logo. Okay, the rest are different, so it becomes a bit more interesting. That's number 4. Number 5, This says 3 people die every day because there are not enough organ donors. So that's framing it as a loss. Now compare that to number 6, which says you could save or transform up to 9 lives as an organ donor, which is framing it as a gain. 2 more. Number 7, if you needed an organ transplant, would you have one? If so, please help others. So that's that sense of give and take, reciprocity in the jargon. And the last one, if you support organ donation, please turn your support into action. So it's to bridge that gap between people's good intention and their perhaps less good action. Okay, I'm going to run back through them again. And this is where, show of hands, one at a time, which one you think was most effective. So number 1 is a simple message. Anyone? Okay. Number 2, social norms message. Still no one, or maybe there's just this peer pressure in the group. No one wants to put their hand up. Okay, let's go. So no one social norms. Number 3, social norms with the people picture. Okay, maybe a dozen. Social norms again, but with the NHS logo. Oh, there was a half a vote. Okay, you can have another half a vote. Number 5, the loss framed message. Okay, maybe a dozen as well. Or the gain framed message, number 6. Oh, that's the popular one so far. Number 7, that reciprocity, sense of give and take, a few people. And the last one, that turn your good intentions into actions. Okay, so the most popular one you went for was the gain framed one, wasn't it? You could save or transform up to 9 lives. I'll show you the results. So those are the results. So first of all, the proportions are small. Most people who are renewing their car tax don't join the organ donor register at this case, but the volumes are so big, 40 million people a year, that these differences matter. The red one, would you, is that reciprocity one. You know, would you take an organ donation? If so, please help others. So that was the most effective, that sense of give and take. And it's the same concept as in the text message at the beginning, that sense of caring about the NHS, caring about other people. So really important concept. The one to pick out is the people picture, which a few of you went for. That was worse than nothing. So adding in, we didn't test it on purpose. We only tested things that we thought were better. But for reasons we can't fully explain, maybe it looked a bit too marketing-y, I don't know. It would have made things worse. So it shows the value of testing, because otherwise we would have inadvertently made things worse. And the other one I'll pick out is those loss-framed and gain-framed messages. There's a hand up. Shall I just go on? We did not get any follow-up data. Again, it was limitations of our research methodology rather than it not being a good idea. I'll just pick out one more result here and then I'll stop. The loss-framed versus gain-framed. So framing something as a loss tends to be, this is across most circumstances, more impactful than framing something as a gain of the same value. So if you found a £20 note on your way into the town hall this morning, you'd have been happy. If you then lost £20 on your way home later, you'd be sad. But overall today, you've gained and lost nothing. But actually, you'll just feel a bit more sad because you feel losses more than the benefit of the gain of the same value. That's just the way we all are. So, but we tend to get this wrong because we think gains are more happy and positive. But in this case, so most of you were wrong, basically, is what I'm saying. Those of you who thought gain was better than a loss, that isn't the way people actually behave. But yeah, it made a really big difference. This is still in place, so we're still seeing an effect. This is still, for no money at all, increasing organ donor registrations. I'll stop there. I'll send those links around. I'll send the cards around, but you'll need to print them out and cut them out yourself. And then if you wanted to get in touch, happy to. My email address is on the front of the slides. Thank you.
Thank you very much. Thank you very much, Daniel. There's so much synergy between what you're talking about and the stuff we're learning about in terms of generating ideas, testing, using data to help inform your strategies. Fantastic, really, really good. And at the end of it all, the key things are this stuff is simple,